Today, we're cracking open a really fascinating medical case file. It's a true story, a real-life mystery that all starts with a body in total chaos. Our job here is to unmask a pretty rare condition called Zollinger-Ellison syndrome. So let's dive right in.
Okay, just imagine this for a second. Your stomach makes acid to digest food, right? It's a powerful, absolutely essential process. But what would happen if the off switch just broke? What if your stomach's acid factory was stuck on high 24/7, just churning out corrosive acid with no way to stop it? Well, that's the exact problem we're going to investigate today.
So when this relentless acid production is happening, doctors have a name for it: Zollinger-Ellison syndrome. You know, it's a rare and pretty complex condition, and to really get it, we have to follow the clues, kind of like a detective on a case.
And that brings us to our first section. It all starts as a mysterious condition. So let's follow those first clues that tell us something is very, very wrong.
So what are the first signs? Well, the initial clues, they often look like severe peptic ulcers, but with a twist. These ulcers are incredibly aggressive. They show up in unusual spots, and they just don't respond to standard treatments. And to make things even more confusing, for up to 40% of patients, the first symptom isn't even stomach pain. Nope, it's persistent diarrhea, which can throw investigators completely off the scent.
All of these clues, though, they point to a single hidden culprit. In this next part, we're going to identify the source of all this chaos, something called a gastronoma.
So what in the world is a gastronoma? Think of it like this. Your body has a system for telling your stomach when to make acid. A gastronoma is a tumor that produces the go signal, a hormone called gastrin. It's like a rogue foreman that completely hijacks the factory and just orders non-stop maximum production. This one little tumor is the engine driving the entire syndrome.
And where do these rogue tumors like to hide? Well, they can pop up in some pretty unusual places, but the vast majority, a full 80% of them, are found in a very specific area: the pancreas or the wall of the duodenum, which is that first part of the small intestine.
Now, here's something that's absolutely crucial about these tumors. They aren't just disruptive, they can be really dangerous. About half of all gastronomas are malignant, and that means they're cancerous and have the potential to spread. And just to add another layer of complexity here, for up to 60% of patients, the gastronoma is actually part of a bigger genetic syndrome called multiple endocrine neoplasia, or MEN. Basically, it's a condition that causes tumors to form in the body's hormone-producing glands. So that means the gastronoma might just be one piece of a much larger puzzle.
So, you've got this hidden, potentially cancerous tumor causing all this havoc. How on earth do doctors track it down? That's what we'll get into next, the medical investigation.
The diagnostic process, it's kind of like a funnel. You start broad and get more and more specific. It all begins with that initial suspicion, based on those stubborn symptoms we talked about. From there, it moves to a key blood test, then a special provocative test to confirm the source, and then finally some advanced imaging to pinpoint the tumor's exact location.
The first major piece of evidence? It comes from a simple blood test that measures gastrin levels. In a healthy person, these levels are pretty low, but in a patient with a gastronoma, they can be sky high. A reading over 1,000 picograms per milliliter is a massive red flag. It pretty much confirms the diagnosis right there. But what if the levels are high but not definitively over that 1,000 mark? Well, doctors have a really clever confirmation step called the secretin provocative test. And here's the wild part. In a healthy person, if you give them an injection of the hormone secretin, their gastrin levels actually drop. But in a patient with a gastronoma, it does the exact opposite. The levels spike dramatically. It's this unique reaction that essentially makes the tumor confess.
Okay, once the gastronoma is confirmed, the hunt is on to find it. Doctors use a whole high-tech toolkit of advanced imaging, things like CT and PET scans. A particularly effective tool is the octreotide scan, which uses a special tracer that literally makes the tumor light up, revealing its precise location, no matter how small or well hidden it might be.
All right, with the culprit identified and located, it's time to act. The next step is a three-pronged treatment plan designed to manage the case.
The first and most immediate goal is damage control. So prong number 1 is all about controlling the effects of that runaway acid production. The main weapons here are powerful acid-suppressing drugs called proton pump inhibitors, or PPIs. You might even recognize names like omeprazole. These medications are incredibly good at shutting down those acid pumps in the stomach. Now, unless the tumor can be completely removed, patients will probably need to take these for the rest of their lives. In some cases, octreotide injections can also be used to help rein in that acid production.
But just controlling the symptoms, well, that isn't a cure. Which brings us to prong number 2, removing the source of the problem itself.
And this means surgery. For patients whose tumor is just in one spot and hasn't spread and isn't part of that broader MEN syndrome, surgery offers a potential cure. The surgical cure rate in these ideal cases is about 20 to 25%. So while it's certainly not guaranteed, it's the best shot at a permanent solution.
And finally, we have to deal with the most serious scenario. What happens when the cancer has already spread? That is prong number 3, addressing metastatic disease. When the gastronoma has spread, chemotherapy becomes the primary tool. And while traditional drugs have been used for years, newer agents are always being investigated. These modern therapies, they show a lot of promise in reducing the tumor mass and improving survival for patients with advanced disease. The goal is to stop its progression.
So, after all of this, the diagnosis, the hunt, the treatment, what's the long-term outlook? Let's close the case file in our final section, the outlook and prognosis.
You know, the long-term prognosis really hinges almost entirely on how successful that surgery is. For patients where the tumor is completely removed, the 10-year survival rate is over 90%, which is an excellent outcome. But the contrast is just stark. If the removal is incomplete, that rate plummets to just 25%. This really drives home how crucial it is to find and remove these tumors early.
And so, our case file closes. This incredibly rare disease, it shows us in such stark detail how a single hormone made by one tiny rogue tumor can throw the entire body into a state of crisis. What does this remarkable case teach us about the incredibly delicate and often invisible balance that keeps all of us healthy every single day?